Just like Professor Mary Jacob influenced your life and career, I am certain that you have also positively impacted generations of trainees who had the privilege of working with you. Today, what advice would you give to medical students and internists who are considering neurology as their career?
Yeah, David, it's very interesting. People feel that the medical career is not so charming anymore, but I disagree because even after 3 decades of being a doctor, I still enjoy my work. There is no better feeling to see a person who's crying or who's upset get better and then go with a smile. It is not only the treatable diseases, but there are some conditions we know that we cannot cure, but even there we can make a difference. The way we deal with the patients, the way we talk to them, we give them hope, we listen to them. Listening is one of the most valuable things we do as doctors. Many patients tell me, the doctor, I know that there is no treatment for this, but you listen to us and you have a smiling face, so that makes a difference. My advice to junior doctors is that the most important thing is listen to your patients, because patients will tell you the diagnosis when you listen to them. You don't have to stop them and put our questions, so just listen to them. Second thing is, if they have any concerns, questions, resolve them, answer them. This, they are already in pain, they are having troubles. So at that time, if we show our kindness, it's not kindness, it's part of our job. And thirdly, be truthful. Sometimes we have difficult news to break, grade 4 cancer, where outcome may not be good. So we should learn the art how to convey the bad news in a proper manner. Analyze the family, the person, how much they can take, and if possible, break into two or three different meetings. If everything cannot be covered in the first session, so this all this makes a difference. I've had patients with ALS or MND who have come and thanked me when I told them there is no specific treatment to cure you. But the fact that I was able to listen to them, I could tell them what to do and how they can manage better. So we should be patient and answer them. And medicine is a very charming specialty. Neurology is also very very unique. I love neurology because in most specialties, it is lab oriented or investigation oriented. Nobody can diagnose hypothyroidism without seeing a TSH. You may be knowing all the clinical symptoms and signs, but you need the TSH. You cannot diagnose diabetes without having a blood sugar of more than 140 or HbA1c more than 6.5. Patient may be having all the symptoms. You cannot diagnose renal failure unless creatinine is high. But fortunately for us in neurology, the most common conditions we don't need to do a test. Migraine, almost 15% of people suffer from it, but diagnostic criteria is based on the symptoms. Similarly, epilepsy, half the cases of epilepsy, the EEG may be normal, MRI may be normal, but the description of the seizure, it helps us make a diagnosis. So it is still one of the old-fashioned specialties where we need to listen to the patient, examine the patients, and then come to a diagnosis. And the tests, they only help us confirm the diagnosis or exclude some other causes. So that is the beauty of neurology.
Thank you for sharing your advice. Let's go a little deeper into some of the things you've just mentioned. The significance of neurological history and examination was drummed into us during our training at CMC Vellore. I remember you talking to me about this during the first few days of my neurosurgical training. However, when I left Vellore to work in hospitals abroad and in India, to my dismay, I noticed that history taking and examination were not being given importance to. Sudhir, in your own words, would you please explain why a detailed neurological history and examination is critical in the effective treatment of patients? This question is again focused at medical students and neurology and neurosurgery trainees.
Yes, David, very interesting question. And here I will do a little bit of give and take between neurology and neurosurgery, even though at Vellore, as well as in Apollo Hyderabad, where I work now, it was a department of neurosciences where neurologists and neurosurgeons we work together. But somehow, there are some neurosurgeons who look at the scan, your scan is normal, nil neurosurgery, nothing is required. But the patient, still is unsatisfied, because as a doctor, we need to tell the patient what the problem is. It matters to a neurosurgeon whether surgery is needed or not. but the patient has come with a problem and patient needs to know what is the disease and what can be done. So that is where history examination are important. Second thing of importance is, suppose somebody looks at the scan. Let's say there is a small disc prolapse in the lower lumbar region. If you do 100 scans, 10 or 15 may be having that. But is that causing a significant symptom to the patient or not? History examination are important there, because if the slip disc is causing symptoms, then doing a surgery will be helpful. I know many neurosurgeons who take very good history examination, and they're as good as a neurologist or even better than neurologists. One of my senior neurosurgeons used to say in Vellore that a good surgeon knows when to operate, but the better surgeon knows when not to operate. And also for neurologists, if we look at the MRI may show some hyperintense lesions. But whether that is demyelinating illness, whether that is stroke, whether that is infection, so that information will get only if we take proper history. How many days the illness is there, whether it started all of a sudden or slowly. So both for a neurology resident and for a neurosurgery resident, and even for a medical student, history examination cannot be replaced.
So that's wonderful. And that has been my experience too. When I was a trainee at Felor, our morning rounds used to consist of about a couple of hours in which the resident or the trainee would present the neurological history and examination findings to the consultant. And at the end of each case presentation, the first question the consultant would ask, what is the anatomical localization? And based on the history and examination, we as trainees had to tell them where the lesion is located. And that was very important because on clinical examination and history, if we can localize a lesion to a certain point in the brain and spine, we have to then compare that with the patient's MRI to see if there's an abnormalities in the same point. Suppose there's an abnormality present there, then we are certain that that particular abnormality is causing the symptoms, and hence a surgery of that abnormality would alleviate the symptoms. So that's very important. I feel history taking and examination should be at the forefront of all medical training programs, irrespective of the specialty.